here with Dr. Nelly Salgado de Schneider, who's here with us today. Nelly is specializes in the investigation of social factors as determinants of risk and vulnerability in the development of mental and physical health problems amongst Mexican immigrants of Mexican origin. And thank you, Nelly, for being here with us. And I also have the honor of introducing you to Lucia Abascal. She's a public health professional, and she's a researcher very dedicated whose work focuses on promoting uh, health equity and addressing disparities in vulnerable populations. And along with them, I had the privilege to share this space and talk to you about vaccination among adult Mexican males. Nelly's, if you will, take it away. To start with this virtual seminar. Next, please. So we can start with this virtual seminar, the previous one, please. I think we still have a little bit of time. And yes. To start with the seminar, you need to know a few things. First, that this seminar will be completely given in Spanish with interpretation into English, and there's two things that you need to know. If you need to use English, you should need to go to this globe icon, which is the interpretation function in Zoom, and you need to choose your language of preference. That's the first. The second one is you need to choose the screen that you want to view in English or in Spanish. So you need to go to the top of your screen and click on options, view options, and you'll find a menu that will give you the option to see the slides in English or in Spanish. Of course, this virtual seminar will be recorded and it will be made available to you in the future along with the slides. MCN is accredited as provider or continuing education by the uh, American Nurse Credentialing Centers Commission on Accreditation. So you can request this. We have also applied to offer continuing medical education. And if you answer the survey at the end of this webinar, you will be given those credits. It's important for you to know that neither MCN nor the presenters of this session have any relevant financial relationships related to what we're going to discuss today. This is very important for you to know. Next, please. I think there's one before that one. No. What I want to tell you then is that this presentation is supported through an independent grant from Pfizer for medical education. So with this, we can start and go into the objective of our session. What we want to do is to identify with you the social determinants of health, the obstacles and challenges for successful vaccinations for men who are Spanish speaking, Latino, or indigenous with roots in Mexico and Central America. We'll also discuss examples of successful vaccine campaigns and research on vaccine promotion with indigenous groups in Mexico and Guatemala, and among immigrant and migrant populations in the US. And then lastly, we're going to identify vaccination, uh, hyperlocal vaccination strategies and resources that MCN has developed to address vaccination amongst men who are Spanish speakers or are part of vulnerable populations. And being said this, I pass it on to Dr. Nelly. Dr. Nelly, please. Thank you very much, Alma. Good afternoon, everyone, and welcome to this webinar. I am delighted to be able to share with you some ideas, some research updates, and some important recommendations around vaccination. And vaccination, not in general, but specifically speaking about vaccination in men. In this presentation specifically, we're going to talk about vaccination in men of Mexican origin. To start with, I want to begin with something that most of you might know, is that vaccination is the single most important preventive medicine action worldwide. If we had to identify the most perfect way or the closest way to achieve total health, it would be through vaccination. However, we've had a lot of issues with the distribution of vaccine, and it's evident that there are great inequalities in the distribution of vaccinations worldwide, which is a challenge for big organizations and for governments in all countries. In the US, for instance, there are tremendous inequalities for people to get vaccinated, especially amongst men that belong to ethnical and racial minorities when we compare them to the rest of the population in the US. Some of the barriers for vaccination or access to vaccination among minority group males are complex, and and many of them are strongly related to traditional gender roles, whether it's because of the job they do or because they can't or won't miss work because they do not earn money that day, or because they lack the knowledge, or for many other reasons that we are going to discuss today later on. So in general, what literature shows is that Latin groups, Hispanic groups, have the lowest rates of vaccination compared to most other race or ethnic groups that live in in the United States. I would like to clarify something here. Is this means this statement speaking directly to life in the US? When people migrate and their destination country is the US and they migrate as adults, many times they've already had been vaccinated in their countries of origin. In Mexico, for instance, we had a very successful campaign, a universal vaccination campaign, in which many people were able to get vaccines. But once in the US, if they need a booster, they don't have access to those types of vaccines. Where is that? Let me see what's going on. All right. So, what healthcare providers report, some of the reasons why adult patients, males in particular, do not receive their vaccines are many, but amongst the main ones are the ones that I'm showing in this slide. First, cost. In the US, as you know, the cost of vaccines is very high when compared to, for instance, the cost in some of the countries in Latin America. For instance, in Mexico, some vaccines are completely free, and you can get them in health centers. So the first element, the first barrier will be cost. Another element that might not be that important, but it is the they reject the needle opposition. They try to avoid pain. And so what they say is, if I don't have to get a shot or a vaccine because they don't ask for it at work, then I rather not do it. Uh, thinking that that workplaces don't necessarily always require vaccines, but us as adults need vaccinations to keep our health, preserve our health. Another important reason is unwillingness to miss work to get vaccinated, because missing work implies not getting paid that day. And in the end, the last everything comes down to the last item here: lack of knowledge about the benefits of vaccines. They don't have the information about what the great health benefits of vaccines in general, the people, the clinicians report that people that are more hesitant about whether getting a vaccine or not are male adult Hispanic patients compared to other population groups. And also the health systems in general worldwide exclude or seem to exclude males because there's significant focus on immunizing pregnant women and newborn children, but not for men. So they're excluded. In fact, we know that women in general know the health system much better because as caregivers of their children or their parents or maybe other relatives, uh, this also involves healthcare. So women are more familiarized with the way you can get health services in any system. Now, the misinformation of parents regarding vaccine or erroneous beliefs around vaccines not only affects their own health, but it may prevent their children from getting vaccinated, and that puts them in danger. I'm going to talk to you a little bit about what we have been able to achieve in Mexico. Mexico began its national vaccination campaign since 1973 by applying 6 biologics included in 4 essential vaccines. BCG, which is the tuberculosis vaccine, the polio vaccine, the DPT, which includes diphtheria, pertussis, and tetanus, and the measles vaccine. And this program launched in 1973, this national vaccination campaign, which was very successful, so successful that by 1991, the vaccination was declared a universal right. So we started the universal vaccination program, which focused on administering 8 vaccinations to children under 5 years of age. And for at least 3 decades, this universal vaccination program, achieved a coverage of between 73 to 98% in children under 5 years of age nationwide. Mexico in vaccinations is and has been a very important example for many countries. Unfortunately, over the last few years, things have changed, especially in the last 6 years, the last decade, things have changed. And with the restructuring of Birmex, which is the company that manufactured vaccines at a national level, that was created in 1999, we lost financing, and with COVID-19 in Mexico, we offered the Sputnik vaccines from Russia, the Bala from Cuba, the Cancino vaccine from China, and the very famous Patria vaccine that was supposed to be developed in Mexico, but it was not produced on time for COVID-19, unfortunately. So this has made the program, the universal vaccination program in Mexico, I don't think it's halted, but it's been paused in a significant way. So it's also important to recognize that there is an effort to recover this lost time through a national vaccination campaign that has just started in April. It's April and May, and it's a national in 2024 in which you're going to offer the measles, rubella, and polio vaccines to children and teenagers. So hopefully with this restart of the vaccination campaigns at the national level, they can be as successful as they were before. I want to talk to you about some research we conducted here in Austin. We did it at the Mexican consulate here in Austin, Texas, through or with the support of MCN and the Ventanilla de Salud. And this was in 2020.
we were looking why Mexican adults are not getting vaccinated, and we interview we 401 Mexican males with age range between 18 and 17 and 79 years old. And we want to know why they are vaccinated or not. And we thought that it would be important because it will help us to understand the reasons behind getting vaccinated or not. And also it will enable us to reach them. I will share some results. What we found is that men in general are they considering that vaccinations are important for their health. That is very clear. But they just think that it is important. They don't know the reasons why it's important. They have a very limited knowledge on the real benefits of vaccines and how to access to those vaccines. And consequently s- they do not engage in this vaccination, nor they give priority to this as a preventive health practice. As a matter of fact, almost half of the respondents have not been vaccinated in the last 5 years, and they have the erroneous belief that they didn't need a vaccine because they did not feel sick. So this is very interesting how the young men, especially those younger than 40, they were less likely to take care of their health or to vaccinate or to get shots because they saw of themselves as healthy. And so they say, there is no, I'm a healthy person. I don't have any problem. So they were confusing vaccines with medications, and they thought that vaccines should be only be administered in case of medical intervention for illness and not as a preventive measure. In many in many Mexican families, especially from rural areas, the family life it is turns around male dominance. So the men guide their families. That's the reason why we need to insist in vaccination of men. And in vaccination, it's extremely important that men get their vaccines to to make sure that all of the family members are vaccinated through example. And we know very little how much the role of culture in the beliefs, the attitudes, and the behaviors towards the towards the vaccines by the male young male members from Mexican origin. I will share some of the recommendations from our findings and also the review, mm, the material review. First, it is really important to insist in the importance to work on education to to increase the literacy in vaccines, to make them understand that vaccines are not medications, but they're not medicines, but we need to use a narrative in their existing vaccination campaigns that focus on men as providers of their families and therefore prioritize their acceptance to vaccine as a preventive measure that it will benefit the whole family. Very often Mexican men are the only or the main providers of their for their families. That's why it is so important discussing as part of the this campaign about the importance of the vaccines to discuss the financial impact that a health-related incidents could have in the family welfare, and that it could be avoided with the vaccination. Another one is also the support of the employers. so men can seek vaccines. Also, coordinations between the mobile clinics and the employers to bring vaccines to the workplace. Many of the men that we interview, they say, no, I cannot leave my workplace to get my vaccinated. But if it is offered to me in my workplace, I will do it. So, a very clear recommendation is to invite employers to bring vaccinations to the work site, to the farms, to the construction sites where these men work, that will enable, that will make it easier for the for men to get the vaccinated. And due to that, the decisions of the men have so much weight within Mexican families, it's really important to educate men about the benefits of the vaccines, and especially all the benefits in terms of prevention, not just for the father and the mother, but also for the children. So their decision to get vaccinated or not is, at the end of the day, is their own. But what it is really important is that mother and father are aware of the importance of vaccinating their children. So uh, having the men vaccinated is an example for the importance of vaccinating the children as well. Here are some bibliographical references that you can look into about vaccination in men, in adult men from Mexican origin. And with this, I end my presentations. We will take questions later on. So I pass it to Lucia. Go ahead, Lucia. Thank you so much, Nelly. Just I'm going to change. Thank you so much, Nelly. I'm going to be talking. Thank you for being here in this very important uh, call. So I'm going to be also talking about vaccination, but I will be focusing more on risk communities and communities at risk. As it was already been mentioned, the minority groups have faced significant disadvantages in vaccination access, and it's a problem because those are the ones that were more that will benefit most of vaccinations. There are many reasons, but fear, misinformation, and polarization on health issues have worsened since the start of the COVID pandemic, and it has resulted in a decrease on the willingness to get vaccinated, not just the flu, but also many adults decided not to vaccinate their children, and we know that this is going to have also impacts on further on. So I like to work. I would like to start this. Don't ask the elm for pears. That it is that means that we cannot ask for the impossible. That has to do with the responsibility of the individual. It is not people's fault not to get vaccinated. The system needs to really help, and also not to ask the impossible. For instance, the person who speaks an indigenous language and then tell them come on and get vaccinated. Clearly, that's a communication error. We need to understand what are we asking and why, and also looking for. I was looking for the translation into English. Excuse me, doctora. The interpreters are saying that please go slower. Yes, when I have the opportunity to talk, I'm sorry, interpreters. So we cannot ask the impossible to people, and within this, that also applies to vaccination. So I will focus in four projects. I've been working for the last years. I've been working in COVID vaccination in several populations in Mexico and in Guatemala, and also in migrating communities in California and the Bay Area. So I will start what we found in San Francisco regarding the COVID-19 vaccinations among the Spanish speakers. Why is this important? Because when the pandemic started, the Latino population, especially the ones who were not born in the US and who were not proficient in English, were the most affected by COVID. And just to get an idea, in the first half of 2020, when the pandemic started, 80% of the people hospitalized in San Francisco by COVID were Latinos, but they only represent 15% of the population in that city. So clearly you could see that there was an important imbalance. So we were commissioned by the city, the public health department, to try to understand what were the barriers, so for people not to accept a preventive measure. So we started mm, mm, with uh, with quarantine, and then when the vaccine was issued, then we started looking into it. So what we found, looking into vaccinations, I will be talking about system level barriers, and then also individuals. But it doesn't mean that the individual barriers are the individual's fault. In terms of the system, what we found, and we did it through qualitative interviews, is that the system and that offer the vaccines were not coordinated. So they will tell you, no, you need an appointment, and then they will tell you where you could go without an appointment. And this is really critical, because we know if the person i- is denied the vaccine, then it's very unlikely that it will go back. Also, the eligibility criteria were very confused. They will say, now people who live in this zip code could be qualified to get a shot. But people didn't know if they qualify or not. In terms of the physical environment, many of the vaccination sites, when we had this mega site, they were very difficult to access if you didn't have a car or if you have a disability. That changed, and then we saw that if you have a community center that it is less than 3 blocks away, is more likely that you will get vaccinated. And also the social environment in your home, if they are pro-vaccine, then it is more likely that you will get the shot. And then something that we will see with migrants is the social network, the international uh, uh, the, uh, the the social media, that they were getting the information from their home countries, and saying that the vaccines they were not good, and these are also the barriers, and they are not fault of the individuals, but there are some things that you can act on. So what we saw is that there was a very poor inten- or limited understanding of the safety and effectiveness of the vaccines. The people didn't know if they were safe and they were effective. The role of social media and the misinformation, and that was not applied. They only apply just to health, but also to politics, and definitely that was applied to COVID-19, and also the limited literacy, digital literacy. And I will give you an example. San Francisco is a very tech city where there is much technology,
They had the first registration, online registration for the vaccination. You can imagine who were the people that had access to this. Sometimes I asked Google accounts that not everybody has, right? So what this did was give a priority for vaccination to groups that had access to technology and knew how to use it, and not to those who most needed it. Something that is very important, that is not surprising, is the fear of side effects, both the immediate ones, that I'm going to get a temperature like a fever and I'm going to feel sick, and also long-term side effects, because this is important to differentiate, because we see this also in children's vaccinations, because this is interesting in other countries, where Mexico and Guatemala, where I also done research, the fear of parents to vaccinate their children is more to the immediate side effects. They're going to feel pain and the vaccination sites, etc. But in the US, the fear is for long-term side effects, for instance, autism, or longer term fears, and understanding what these fears are in the populations we're working with will be super important, because it's not the same thing for me as a doctor to come to see a patient and say, hey, over the next 2 days, uh, you or your kid, you might have low grade fever, but don't worry, drink water, take Tylenol, and everything's going to be fine. Or having to say, over 10 years, in the next 10 years, that you're not going to have any other kinds of problems. So we need to be important to differentiate where fear is and what the fear is about. Doctor, yes. Again, please, can you go a little slower? Apologies. Yes. I'm sorry. And lastly, concerns about the legitimacy. I mean, why was the vaccination developed so quickly, the COVID vaccine? And why is the government so interested in us getting vaccinated? So for people that work in communication for vaccination, it's very important to be able to respond to these questions. And what are the recommendations? What are the outcomes of this study? We provided some recommendations to the San Francisco and other counties in California, the health Department of Public Health of these counties, and to the Department of State. And this is like the beginning of the vaccination. So what we found is that the main barriers we found in our populations in San Francisco was more geared to the health system, but also fear. Our most important recommendations were education. There's a lot of lack of education that could be addressed through communication campaigns. And I'm going to share with you a little bit of another study that we conducted in Mexico. Unfortunately, in the US, it's a little complicated to do studies, do research in immigrant indigenous populations, because they're not sensed. I mean, we don't have records of how many there are, and sometimes they are lost because they identify as Latin or another category. So this is more based in Mexico, but I think it could be easily transferred, or very well transferred, to indigenous Latin American indigenous populations in the US. So we use this huge survey that we do in Mexico regularly, and represents all the country. Why is this important? Um, and this is something that we share in a COVID report recently in Mexico. I'm showing you this graph because in blue is the death rate in indigenous populations, and in the red bars there's no indigenous people. So we can see from the first wave, in indigenous populations in Mexico died at higher rates than non-indigenous populations. And many explanations have been we've tried to explain this, like not having access, or them being at higher risk. But when you see that we started with the vaccination campaign, death rates amongst both populations, they decreased, but we still have deaths, more deaths in the indigenous populations. But when we have Omicron, we see that the death rates among indigenous population remains constant. And we were able to vaccinate non-indigenous people, and we had a disproportionate death rate with indigenous peoples in Mexico. That's why it's so important to understand this. And so what we found was that if you spoke an indigenous language, you were more prone to not being vaccinated. Why? Because of negative beliefs. More people that spoke indigenous languages would say they did not get vaccinated out of fear. And amongst men, there was 20% less likely to have a COVID vaccination in comparison to women. And what was so interesting about this project, because we compared the reasons why they didn't get vaccinated, is that traditionally we think that indigenous populations don't get vaccinated or don't have access to any health service because they don't have access to it. We imagine they live up in the mountain and they have no doctors around. And what we found is that, in fact, the populations that did not speak indigenous languages have more barriers to access, but populations that spoke any indigenous language reported more barriers that have to do with fear or belief. So this is something we didn't know. So amongst the reasons not to get vaccinated, and I want you to see the difference. One of the most reported one is that the vaccine hasn't gotten to where we live. That's just merely of access, but and people that don't speak indigenous languages, 16% of the people say that that's the reason they did not get a vaccine. But amongst people that do speak an indigenous language, it was 11%, so 5% less. And side effects, it was 15% amongst populations that don't speak indigenous languages, but 19% of people that speak indigenous languages, as well as fear. We see was what's one of the largest reasons amongst groups, but it was reported more amongst the indigenous speaking people. So this is a space, this is an opportunity to communicate that has not been filled. And this study really complements well with some studies that we have conducted in Guatemala with indigenous populations, where we find that there's a lack of information about the COVID-19 vaccines that is understandable, and that it is in the languages that those people speak. We can't expect them to understand the language they do not speak, and that it is culturally sensitive or relevant. Here in Guatemala, we do have an access and supply problem and misinformation and disinformation, which also affects the willingness of people to get vaccinated. We also complemented this with a survey where we found that the most common reasons not to get vaccinated against COVID-19 were, once again, side effects, the fear of dying because of the vaccine, and the lack of information about the vaccine. This could be from where I don't know where to go get it, or I don't know what this vaccine is for. And we also had this idea that people with certain diseases like diabetes could not get vaccinated. When I go back to saying these were the people that needed the most. So we created a campaign, an information campaign in their languages, seeking aimed at those communities. See how this woman has a traditional outfit or dress, and with this is in Quiché, Cachiquel, and what we found is that the videos, we did this on social media. Videos appear to improve the perceived safety of vaccines. So Quiché is an indigenous language. So when people see the videos in Quiché, it makes people feel or know that the vaccine is safe. And we also found a difference in the the groups that saw the videos in Spanish, but it wasn't as big. And also the assessment of this program found that those who had watched the videos about information uh, about vaccinations were 70% more likely to get vaccinated, which is really high, which suggests that the videos that are linguistically and culturally adequate can help to increase trust in the vaccine. So just to to finish, our findings underscore the importance of providing vaccine information that is culturally and linguistically appropriate and address the barriers to access and misinformation. And the studies in these three countries show that targeted strategies can make a significant difference in vaccine acceptance among these populations, including Spanish speaking and the people in the US and indigenous communities in these countries, and especially with men. And so we're doing this project right now with indigenous migrants in California, And we are launching a national campaign for childhood and HPV vaccination in Guatemala using the same method. So there's a lot to do still. I hope I didn't go over time, and I'm sorry I spoke so fast and over here answering your questions. No, no, Lucia, Nelly, thank you so much for sharing all your experience and research that you're doing. I'm going to now start sharing my screen, if I may. Can you see my screen? Yes, Anna, we can. Wonderful. All right. This last section is to talk to you a little bit about the strategies and resources that MCN has developed to address all these issues that Nelly and Lucia are showing us or bringing to light. And I'm going to talk to you about the strategies and the resources, specifically the vaccination, the COVID resource center that we developed, and some comic book materials called Older People Also Get Vaccinated, Adults Also Get Vaccinated, and uh, a communication component, talking about what Lucia was saying, how hyperlocal communication strategies are very important. And to start, I need to share with you that all this work that MCN does is based in this health promotion strategy. We obviously uh, have this objective of moving or advancing public health, and that everyone has the right to wellness and not just be free of disease. Also, our focus, we focus a lot on linguistic justice, language justice. That means that we all need to receive services in the language that we understand, in the language that we feel more comfortable in, and the system has the responsibility to respond to this. Of course, health equity is a very important part of all the work that MCN does, and working in popular education, where we just only go and provide or void the information, we'll give the information to the people that we are interacting with, but we also, with them, alongside with them, we make them participants to share the information. And when there's research, it says that as long as people, or the more involved people are in the development of learning strategies, the results are much better. And the last one, the last focus that we take is community participation. We include them in the decision-making process and in the development of interventions. If we do this, obviously, results will be much better. So both strategies that I'm going to share with you are, one, how to use uh, community health workers as a public health strategy and hyperlocal campaigns that address and take into consideration the traits, the socioeconomic traits, the cultural traits, especially cultural characteristics of people that are being served or addressed. Why? Why do we focus so much on these two components at MCN? Well, because we think that these two strategies promote access to preventive services, which is what we need. And also, it gives us the opportunity to manage education cases, management of the system, and it connects the communities to service, to adequate services. It's not just a matter of having adequate materials, but we need to have access to those materials. So the health worker has that characteristic that helps. The other is that these two strategies inform about the services that are provided in a way that is adequately appropriate, culturally appropriate, and also advocates uh, for underserved populations, which means we're doing work in health equity, which is for MCN one of the most important things. With this perspective of research that both Nelly and Lucia have shared with you, it is very important for me to consider these two issues. What is an essential worker and what is critical infrastructure that in the US we place Latin men?
In the US, there are 333 million, that's the population. Of them, 46.2 are immigrants. That's almost 14%, 13.9. So over 70% of these immigrants are considered essential workers. The men that we are referring to in the research are essential workers here in the US. They work in they are agricultural workers. They are working in meat processors, in the dairy industry, also in many of the supermarkets, grocery stores, and maintenance. But they are also health workers. And this map, for me, it's very interesting because it shows the more common uh, occupations of immigrants in the U.S. For instance, I'm here in Massachusetts, and here immigrants work more uh, in maintenance. As in Texas, they work in as domestic workers. In New Mexico, agriculture. In California, agriculture. You will all get this, so you can look into with more detail. But we wanted you to give you an idea of the type of work that immigrants are undertaking in the country. And as I told you, of the 333 million population, 13.9% are immigrants, and of them, 52% come from Latin America, the rest 31% from Asia. And of course, we're not going to go into immigration, but I wanted to give you an idea uh, that from these people who are immigrant, those immigrant, there is 11 million who are not authorized to work in the U.S. 78% are come from Latin America and the Caribbean, and then it's 3% from the Caribbean, and 19% from Central America, and 8% from South America. Why are these numbers important? It's because they give us an idea who will who or materials, education materials should be a target to. And this is also something important. The literacy rate and the schooling rate, not just in the US, because in the US, people in average they go 13 years to school. In Mexico, 9 years of school, and then in Canada, 13 years, and in India, 7 years, and that that shows the level of literacy, and that also informs the way how we should develop our education materials. And I want to clarify something. One thing is the number of years of schooling, and the other is the level of comprehension that we have of the language. That's something completely different. So in general, we have to take into account these elements to develop education materials that are appropriate. But then that means that whatever we develop, it needs to be culturally appropriate, and then also take into account into the language, not just uh, not just include Spanish, but the Spanish that is according to the traditions, the values. Uh, a word, a term in Guatemala could mean completely something very, very different than it does in Mexico, and vice versa. And also the way how it's spoken has to do with power, with the power relations, and who is providing this information and how the information is provided. And as already we saw the literacy level, not just your literacy level, the person who are developing the materials, no, but the people targeted with those materials, and not you, the creator of the materials. And we're also very aware that there is that one single way of presenting the message is not is appropriate. We need to present our message in a participatory manner, no as if we're giving them a lecture. Uh, so to include them as participants in their own education. So as I was saying, the materials that we are developing connect with the people reality, present practical solutions, also connect with what is important, and present concrete things. And here are some examples, and you will be able to access on our website. And if somebody can help me, we will put the link in the chat. This is a comic that talks about vaccinations, and it talks that grown-ups also get vaccinated, and the and they connect with their reality, with the things that they value, like their children, the money, the reasons why they are here. Talk about in a simple way in how vaccination is, what are the symptoms, what are the illness that the vaccines prevent. And it is very important that it is simple and clear. If someone doesn't is not proficient in the language, uh, in this case in Spanish, so the graphic can also transmit the message. And also provides practical solutions. Where do I go? What do I need to do? How I have to do it? So this is part of the educational materials I wanted to show you here very quickly. You will be able to find it this way. You can find it here, and you can download it, and you can see all the educational material. It is also complemented with a calendar that it is addressed, that is targeted to adult men that work in the US, that oftentimes are by themselves and don't have communication with other people. And the idea is that with these materials, the health from the health workers can help. The other thing is the hyper local campaigns where the with the health promoter can do not just a big campaign, but just one targeted to the people who they are that the person wants. If it's working with if they are working with indigenous peoples, with them. If they are working with people from Salvador, directed for them, and so we design a manual that gives also uh, steps and also specific examples so you can see how you can develop this campaign. And this is an example. Vaccination is a communication campaign that everyone can access these materials and can also adapt, and they can change the pictures, they can change the address. Mm, it has different materials printed for social media. We know that many people work more with Facebook or WhatsApp or Instagram. So the communication campaign needs to be a tailor for those media, those platforms. There are also graphics, videos, and all of this could be a tailor. So these are some of the examples. The connection is hope, and that's a poster, and you can change it. You can say vaccination is whatever you want: love, right, happiness. And also you can also change the pictures. And the idea is that the pictures are for the uh, are pictures of the community, so the community identifies themselves. And also we have also videos or how to use these materials. And very quickly I will go through this because you will be getting all these materials. We have an image bank, so you don't have to struggle with finding mm, finding images, and then illustrations, and also with the colors of the different countries that you're working with, and also that reflect the characteristics of the communities that you're working. We have also these resource centers where you will find many materials that can be printed, can be updated. And within this, there are editable brochures. Lucia was talking about how um, how men are afraid of the secondary effects. So there are some for address for uh, children from 6 to 5 years, for people who are pregnant. There are many more. I'm not going to stop. There is a section of frequent frequently asked questions, if where you can find in a very simple way, both in English and Spanish, the FQU, FQA. And there are many other materials in both languages. And with this, I will close, and I will invite you to visit this website where you will find all these materials that I'm, I'm presenting. Well, I will stop sharing, Marta. I will stop sharing my campaign, and I will ask the presenters to turn their video on. So it's 2 o'clock. There are two questions. One is for Nelly and another for Lucia. I'm going to say it. So, do you think that Mexico vaccination has been so effective in children that they had put aside the efforts with the grown-ups? That's for Nelly. And for Lucy, do you think that in some of the counties that offer money for people to get vaccinated, and that resulted into people not getting shots unless they are being paid? Yes, thank you so much for for the questions. Yes, it's not that the grown-ups are not important. Of course they are, but I just keep in mind that the vaccination campaign in Mexico had to be house to house, door to door. So that's why the priority was the children. It's not that the grown-ups are not important. Of course they are. That's the reason why we have this webinar, because we want to promote vaccination among other men. Uh, in Mexico, formerly the vaccination chart was given. It doesn't exist anymore. Now there is the health card, and it's for women to teenagers. Their record is not kept for the children anymore, and Mexico is trying to retake their campaign through this new campaign that it is being launched. We're retaking the polio, mumps and rubella vaccines for children and teenagers at the national level. That was April and May. Now there is data about how this campaign, how the campaign went, and we hope that it will continue. Thank you, Lucia.
Regarding the incentives, there's mixed evidence. What we saw in general that incentives do work. I won't take a long time, but we need to think that when people go get vaccinated, it's not who does and who doesn't get vaccinated. It's more like a spectrum. And people are closer or more farther away from vaccination. There's people, no matter what you do, won't get a vaccination or a vaccine. And there's people that if you talk to them a little bit, maybe they don't really feel like going and they don't think it's that important. But if you tell them, hey, I'll give you an Amazon card, they're like, okay, fine. That's kind of like the middle point where incentives and other similar things work. So like I'm saying, there was a fear, and in some populations you see that when government paid people, it just make people mistrust more. But that didn't have seem to have an effect at systemic level. It's interesting. It, it serves as an incentive, but that's not the first resource to use. There's more space for education and communication than we think. Sometimes they want to do more elaborate things, but what works many times works better is just to give information and education. There's another comment from Guillermo Cenizo. He says that the border public health office of the Texas Department of Health is finishing on a comparison of vaccination between children among children between Mexico and Texas, and it's been doing with the Secretary of Health in Mexico and the vaccination unit in Texas, the ASHS. So yes, well, hopefully you'll share it with us when you have this, and we're gonna follow up on this. And thank you, Nelly. Thank you, Lucia, for your experience and for sharing your research. This is really helpful for us. Please, participants, answer the survey or fill out this survey, especially if you want to get your continuous education credits, both for nurses and doctors. Thank you, Nelly. Thank you, Lucia. And thank you to interpreters as well. Yes. Yes. Thank you to our interpreters. Thank you so much. And to all the MCN team that is behind this. Good afternoon, everyone. And if you have any lingering questions, let us know. Send them our way and I'll pass them on to the research.